Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org.
Rediscover Paris.
Our patient care and investments in medical technology show our ongoing commitment to the communities of East Central Illinois. Paris Community Hospital Family Medical Center.
HSHS St. Anthony's Memorial Hospital, delivering compassionate care close to home. From advanced surgical techniques and testing to convenient care for your family, we promise to make a healthy difference each and every day. St. Anthony's, together, we are better.
Thank you so much for joining us today for this episode of Being Well. I'm your host, Keanne Armstrong, and I'm joined with a special guest today, Dr. Subhashish Agarwal, a clinical assistant professor of medicine and the director of cardiovascular services with the Prairie Heart Institute at St. Anthony Memorial Hospital in Effingham. Thank you so much for joining us today.
It is my pleasure, and thank you for having me today.
Well, thank you for coming in today. I'm excited to learn about what we're talking about today. We're going to be talking about heart rhythm disorders and everything that is associated with that. So tell me a little bit about your role at Prairie Heart Institute and St. Anthony Hospital, and get us started with that.
So as you have introduced, I am the director at Prairie Heart at St. Anthony, and with the background I have, the job and role entrusted to me was to not only expand the role of cardiovascular services in the community and beyond, but also go into prevention and develop a device program for our community. There are a lot of individuals, in fact, a large number of individuals, almost 30% individuals have some form of heart rhythm disorder.
Wow, that's
Yes.
a large number of people.
We have been fixated as in the cardiovascular community on plumbing, but there is a large disease which has been forgotten almost, or it is being treated in bigger centers, in academic centers, which is related to rhythm disorders.
Okay.
And conduction system disease. And I was given the role of expanding that at the Prairie Heart in Effingham. And I have been there for the last 2 years. And I'm happy to report that we have done some service to the community. We have brought the pacemaker program, the defibrillator program to our community.
All right. Well, speaking of heart rhythm disorders, talk to me about, is there just one? Is there several? How many are there?
That's a great question. I mean, there are multiple types of heart rhythm disorders, but to make it simple, I actually got a model of the heart here.
Okay.
I just want to simplify it that the heart has 4 chambers.
All right.
2 on the lower side and 2 on the upper side. So we could simplify the disorders as coming from the top of the heart as atrial disorders, and those which come from the bottom of the heart as ventricular disorders. So there are n number of disorders, but the one which we are grappling with on an epidemic level is atrial fibrillation.
I hear that word a lot.
Yes. So in the US alone, we have roughly 3 to 6 million individuals who have atrial fibrillation. And if you look in the global scale, there's a paper published in 2013 by Sumit Chugh out of Ann Arbor, and the global epidemic is 33 million.
Wow, that's a large number of people. Now tell me, what is atrial
fibrillation is disordered firing of the pacemakers, as I should say, in the top chambers. Okay. It's a disorganized rhythm. So rather than the God-given pacemaker working and controlling the heart, you have multiple pacemakers working, and mostly they are coming from the left atrium, the upper chamber on the left side.
Okay.
It gets blood from 4 veins, and there are some muscles which exceed into these 4 veins, and there's electrical disturbances which come from that area. That's one mechanism of atrial fibrillation.
Okay.
There are multiple other mechanisms of atrial fibrillation. It's not a lethal rhythm, atrial fibrillation, but it comes with a high morbidity. it has 5 times the risk for stroke, twice the mortality risk, and 2 times risk for heart failure.
Okay.
So, and the strokes which happen with atrial fibrillation are much more deadly. They have high morbidity. So a functioning, independent individual, 65, productive member of society, can have atrial fibrillation and can develop a stroke, and now is a non-functioning member of society.
Right.
So not only is this a personal loss for the person, but for the family and the society at large. And the cost is tremendous. It runs into billions of dollars.
Well, speaking of this, how would a person know if this is something that they have? What are the symptoms that they might be feeling?
So that's a great question, because unfortunately 60 to 70% patients may not even know they have atrial fibrillation. So there's a large number of individuals who are asymptomatic, as we call it.
Okay.
Some who are symptomatic will complain of feeling a flip-flop sensation, fluttering of the, like in a butterfly, flip-flopping, a sensation that something is palpitations, pounding in the chest.
Right, like their heart is racing.
Heart is racing. Some are more subtle. Some will come in the clinic and complain of fatigue, not feeling right, feeling weak, short of breath, or incidental pickup. They have gone for a wellness check with their physician or their nurse practitioner, and someone checks their pulse, feels irregular. They go to the ER and they are picked up on EKGs, and you find that they have atrial fibrillation.
Okay, all right. So it's the heart isn't beating like it normally would.
So there is dyssynchrony. I should use the word dyssynchrony. There is no synchrony between the upper and lower chamber. They're not talking to each other in the proper way. So electricity is normally flowing from the top of the heart, traversing through the conduction system, and then the ventricles contract, depolarize, as we say in medical terms. And that's one heartbeat. Here, there are multiple pacemakers which are working, and some of them come down to the ventricle. The ventricle is beating fast. There's clot formation, which leads to stroke and downstream issues such as systemic embolism. So we have treatments available now for atrial fibrillation.
Oh, that's good to know.
Yes. And the treatment are initially we can use medications to control the heart rate. So that's a rate control strategy. You're controlling the fast heart rates, so patients, individuals feel better. The second strategy is a rhythm control strategy, where we either electrically shock the patients into normal rhythm, or we chemically cardiovert them, chemically shock them, I should say, using drugs.
Okay.
And there are multiple types of drugs, and depending on the results of their studies, their age, their comorbid risk factors, we decide what drug would best suit that person. And if these therapies fail, then we have a small procedure. It's not a surgical procedure, but it's a small procedure. We call it ablation, where we go in up from the groin and find the areas which are causing the atrial fibrillation and burn those areas. So that's one part of it. And the second part of it is prevention of stroke and systemic embolism. And that part is covered by blood thinners. So for almost 5 decades, we had Coumadin or warfarin. It's a vitamin K antagonist. But now we have other novel agents which have less interaction with other drugs, with the diet, and convenience, and predictable anticoagulation. And they have been a success in treating atrial fibrillation.
Okay.
And if all these fail, then we move on to pacing therapy.
And that's what we have sitting out here on the desk?
Yes, I actually brought some pacemakers today because we were going to discuss a little bit about conduction system disease.
Okay, which one do you want to start with?
So I have this here, which is a pacemaker.
They're small.
They are small, and the history of pacing is very fascinating. You know, it all started many years ago. We actually stand today on the shoulders of giants who lived before us. And I'm in a position to talk about pacemakers. So if you go back in history, there was some connection made even at the time of Hippocrates, who actually mentioned that those who have frequent faints without any manifest cause die. So in a way, he was talking about Stokes-Adams syndrome or syncope or fainting episodes caused by slow pulse rates. So over the centuries, some physician somewhere made some connections. And then in 1889, an English physician by the name of John McWilliam put all these different theories together and gave us the first integrated theory of cardiac pacing. In 1930 and 1928, there was a physician in Australia by the name of Mark Lidwell, in the US, Elbert Hyman, and they made the first artificial pacemaker. It was seen as not right, against spirituality, and they did not get the recognition they should have. But over the years, it progressed slowly, haltingly, and then in 1958, the first battery-powered transistorized pacemaker was built in Minneapolis by electrical engineer Earl Bakken for a surgeon by the name of Walton Lillehei, who was a cardiac surgeon. And while doing surgery in these pediatric patients, they used to develop heart blocks.
Okay.
And the devices which are available at that time were huge, cumbersome, and they required a power outlet. So actually there was a power failure for 3 hours, and there was a tragedy.
Oh, that's terrible.
That led to a serendipitous discovery and manufacture of pacemakers. So there is some tragedy involved through the centuries.
It's been a learning process to
It's
get it
been
to
a
where it
learning
is
process.
today.
That's correct.
So how does something like, does this get placed inside of a person?
That's right. So initially these were outside devices, and then slowly over the centuries, and this is again a fascinating story too, that how it was implanted in the secrecy of the evening for the first time across the pond in Sweden. And it lasted only 3 hours, the first device. And then in the US, it was placed, I believe, in New York area by Wilson, Greatbach, and Chardak. They were our surgeons and engineers. So now they have become miniaturized, and thousands and hundreds of patients throughout the world are living proof of the restorative powers of this diminutive device.
Yeah, it's amazing.
So it's a simple procedure now. Simple incision, a pocket is formed, and we gain access to the veins. Through the veins, we pass 2 leads for the pacemaker. One goes to the lower chamber of the heart.
Okay.
So this is the vein which we are gaining access to. The wires and the leads come down, traverse through this valve, which is called the tricuspid valve, and get lodged into the right ventricle. And a second lead comes and gets lodged in the right atrial appendage, which is right here.
Okay.
And those 2 leads are then put into these sockets here. And this becomes the pulse generator, which you see. The whole procedure takes an hour to perform.
Okay.
Patients can leave the same day.
Wow, really? So it's fairly simple procedure, but yet it's something that
It takes years of learning
Right.
to,
And
and
will-
understanding,
will
but it
help
is
the
fairly simple.
patient feels so much better.
Absolutely. If it is if put in for the right indications, then the patients will feel better.
So what is the difference between the sizes of all these pacemakers?
So I have some other devices which I have brought here today. Those who have low heart function, or we call ejection fraction as we call it, the normal ejection fraction is around 55 to 60%. So those whose ejection fraction is less than 30-35%, they have heart failure. These individuals end up getting something we call a defibrillator. So defibrillators are tachycardia devices. They are meant for fast heart rates. We were talking about heart rhythm disorders. So the ones which come from the lower chamber of the heart are the lethal ones. They can kill, and they can cause sudden cardiac death, which can happen within minutes.
I'm sure that's very scary for the patients that you work with or who have this
And
disease.
for the families.
Yes, absolutely.
So again, history is fascinating. Dr. Michael Murawski is the physician who has been given the credit for the invention of defibrillators. So basically, again, simple technique, the same technique is applied, and a lead is placed in the right ventricle. And it's a passive device in a way that it looks at the heart rhythm all the time. And we program it in a way that if a fast rhythm is detected and the device believes that this is ventricular tachycardia or ventricular fibrillation, these are rhythms coming from the lower part of the heart, then it shocks the patient, the heart, I should say,
Right.
and restores rhythm.
Okay.
So that's a larger device because it has more functions. And
Is that what this is?
so this is even larger than the defibrillator.
Oh, okay.
And this is a CRT defibrillator. This is a cardiac resynchronization therapy. We use this in heart failure patients. In particular, those who have an abnormal EKG, which is called left bundle branch block. So normally the heart is beating like this. In those who have a left bundle, the heart comes like this, and then the other part of the heart comes. So there's dyssynchrony, electrical dyssynchrony between the heart. It's not coming together like a football. It is coming one ball and then the second ball.
Okay.
So here we place a lead on the right side, as I had said before, for the pacemaker or the ICD, and a third lead is put in, which goes to the left side of the heart. And the whole idea is to make the heart synchronous and improve the squeeze of the heart, the ejection fraction.
Right.
So if the squeeze of the heart is low, they're in heart failure, they're not pumping effectively, and they have left bundle branch block, those are the individuals who meet guidelines for the placement of this device. So they are a little larger because it has more functionality inbuilt.
Does it also go where this one?
Yes.
Okay, so they
So-
get placed in the same area.
Typically, if someone is right-handed, I put a left-sided device. And if someone is left-handed, we end up putting a right-sided device.
Okay. All right. Well, we also have a small device here.
That's
This is
right.
very tiny.
Yes.
What does this one do?
So this is a loop recorder, and individuals who have passed out, syncope of unknown origin, we have no idea why, or they complain of palpitations, and we have done EKGs and other extended monitoring such as Holters and event monitors, and have not established a diagnosis, or those who have had stroke and they have seen a neurologist and the neurologist does not know what caused the stroke. We call that cryptogenic. So 30 to 40% of ischemic cryptogenic strokes, meaning strokes of no identification, those are the individuals we implant this loop recorder. And the idea is, again, to look for atrial fibrillation in cryptogenic strokes. In those who had passing out episodes, we are looking for pauses. Did the heart stop? Or was the heart too fast? Or did they have any other disorders such as AVNRT, SVT, ORT? So this is a device which plays that role. It used to be much bigger, and we had to make a bigger incision. But now this is insertable, injectable, I should say.
Oh, okay.
So it's a simple procedure. We inject it, and the patient just walks in, and within 20 minutes, he's walking out of our procedure lab. And this gives us information for 3 years. And this is MRI conditional. So they can get an MRI with all these devices now. So all these devices are MRI conditional. That's the advance. You could not get an MRI before. Now you can.
Okay. Now you said this one is for 3 years. Do these have time?
They do. Initially, it used to be 5 to 7 years. Now they have extended battery life, so upward of 10 years.
Okay. And then for somebody who would have something like this, do they need to worry about it stopping working? I mean, is
So
there a
we
concern?
monitor them, very religiously. Normally in my practice, what I do is that I get the device interrogated the next day. Then in 2 weeks, I look at the wound myself, make sure the wound is healing, check the device, and then we do that again at 3 months. And then every 3 months, they are remotely monitored. So from the comfort of your home, you have a trans-telephonic transmission through a transponder which is near your bedside. And every year, we have you come in for an office visit to check the device in-house. And that way we monitor the battery life of these devices. So once the battery life has depleted to a certain level, we have a 3-month window to replace the battery, which is again a simple operation. We make a small incision, take the old battery out, and put a new battery in.
All right, that's amazing how things have come so far, and it's almost like a Wi-Fi signal that's being sent to keep tabs on your heart. I see that you have a book here as well. Is this something that you want to talk about? Is this something that people can do to help feel better? Is it prevention? What is this?
So, I'm very much interested in prevention, because right now it seems like we are mopping the floor. There's an epidemic of cardiovascular disease, not just in the US, but globally. And again, as we talked about, loss of productivity and dollars spent, but also think about from the individual's perspective. We think on a global scale about production and money, but we need to talk about personalized medicine or individual's level. So we need to turn the faucet off. Cleaning this floor and mopping the floor is important, but we also need to turn the faucet off, and that's where prevention comes in. So I'm a big proponent of preventive cardiology.
Okay.
Lifestyle, the healthy eating, exercise, they go a long way in prevention of cardiovascular disease. In fact, there is a Intermax Hearts trial, which has been ongoing for many years, and they have shown 90% reduction of cardiovascular disease with few things: smoking cessation, move, exercise, eat right, decreased alcohol consumption. All those things led to 90% reduction in cardiovascular disease. And that's where this idea was born about not just one thing in your life, it's a holistic approach to life. And this is one part of the piece where I actually wrote a book called Holistic Yoga. And in this book, I have shown 17 postures which have proven cardiovascular benefits. Not just health benefits, which accrue, but also cardiovascular benefits. And that's one piece of the puzzle. The other part is the science behind it. And the last part is holistic living and cooking.
All right.
You need to eat holistically to get the benefits of good heart and cancer-free.
So take good care of yourself, exercise, eat right, and try to live as best as you can.
You got it.
All right. Hey, we have just a couple of minutes left, and I have another thing down here, the HIS bundle pacing. Have we discussed that?
No, that's exciting. Development, as I said, through the centuries, it has had progressed. And now we are looking at physiological pacing. So as I had said before, when we are pacing from right below, we have found out that it could have detrimental effects on the heart. And if the pacing is more than 40% of the time, it can lead to heart failure. So over the centuries, we have always dreamed of physiological pacing, replicating pacing as close to the God-given pacemaker at the sinoatrial junction. So the HIS bundle, if we can capture that area of the heart, we can almost replicate the depolarization of the lower chambers. So that's an exciting development. I was just at the Heart Rhythm Society meeting in Chicago this year, and this is the latest raise. And we talked about it, we knew about it, but now we are at a point where we can actually implement it.
Well, that's good news to know.
Yes.
So what should a person do if they feel like they have a heart rhythm disorder? We're almost out of time, so I want people to know, should they go to the ER? Should they schedule a visit with their physician?
Absolutely, they should call their physician, get an EKG. If they need to go to the ER, absolutely. Sometimes I understand that patients may not be able to see me or their primary care physician in time. We are in constant touch with the emergency department, with our primary care physicians and colleagues. So if they have any inclination that they're not feeling right, they're worried about it, they should contact their healthcare provider.
And go from there.
And
there's lots of treatments available, whether it be through medicine or AFib equipment, different things like that.
Exciting treatments are available.
All right. Well, thank you so much for being here with us today.
Thank you
It's
so
been
much for having
a
me.
pleasure, and thank you so much for joining us for this special edition of Being Well on heart rhythm disorders, and we hope that it's been educational for you, and thank you once again for tuning in.
Production of Being Well is made possible in part by
HSHS St. Anthony's Memorial Hospital, delivering compassionate care close to home. From advanced surgical techniques and testing to convenient care for your family, we promise to make a healthy difference each and every day. St. Anthony's, together, we are better.
Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org.
Rediscover Paris.
Our patient care and investments in medical technology show our ongoing commitment to the communities of East Central Illinois. Paris Community Hospital Family Medical Center.